Welcome to Westchester Jewish Community Services. As a leading agency in providing a comprehensive spectrum of human services, we have been helping people since 1943. We serve all people in Westchester County, regardless of age, income, or ethnicity. We provide a wide variety of essential and dynamic services that make a difference in people's lives. Children, teens, adults, and senior citizens are served by our network of programs located throughout the county. When people come to us for assistance, they become part of the WJCS family. Our highly trained and skilled staff focus on you and your family and are committed to becoming your partner in finding solutions. For more than half a century, we have been connecting people to services that help them overcome mental, physical, or emotional challenges. WJCS is here in your community when you need us.
Welcome to the Ways We Care of Westchester Jewish Community Services. I'm Dale Wang, Director of Community Relations. WJCS is funded by UJA Federation, United Way, government grants, private individuals, foundations, and corporations. I hope that you will all bear with us tonight. We are taping on the hottest day of July, and we have turned into dress down for the event. So if we look a little warm, it's because we are. When people suffer mental, emotional, or physical problems, the strains and stresses often affect other parts of their bodies and parts of their lives. In contemporary life, there is a great emphasis on physical well-being as it impacts mental health and the power of the mind to influence the healing of the body. At WJCS, through our family mental health clinics, we help people who struggle with many different types of issues. Those issues can often interfere with their successful functioning in daily activities. In some instances, the effort of dealing with a psychological or emotional situation creates very real physical symptoms. In other cases, the strain of coping with a medical crisis can result in the development of adaptive behaviors that may cause other difficulties. On tonight's program, we are going to explore some of the points at which mental health and medical issues intersect, and we will discuss ways that professionals work with individuals to overcome problems that can affect the body and the mind. To consider this topic, we've invited several of our professionals to torture, I think, this evening. Dr. Andrew Levin, who is an MD and who is the WJCS Medical Director. Welcome, Andrew.
Thank you.
Dr. William DeCipio, who is PhD and WJCS's Chief Psychologist. Welcome, Bill.
Thank you.
And Dr. Timothy Locke, who is a WJCS psychologist in several programs, right?
Yes.
Okay. I'd like to begin by discussing the different roles that you have in working with people and how you might interact together or differently to assist someone who comes into our clinics. Bill, maybe you might want to start because you may have a broader perspective.
Okay, well, we first of all, we consider ourselves a family and a team, and very rarely will we work in isolation. We're most interested in a comprehensive overview of any client or patient who comes into the agency by gathering as much information as possible, which may require different disciplines, different people, and different assessment instruments. The more we know about a person, the better we'll be able to devise a treatment plan or something to improve either their physical or their mental well-being.
Mm-hmm. So when someone comes in through intake, how is it determined whether they would see a psychologist, a psychiatrist, a social worker? You know, is there?
Okay, if it's a person who's never been to the agency before, and maybe they've been self-referred, there's many different ways of coming in, we would first of all want to sit down with the individual if it's an adult and find out where else they've been for help, if they've had treatment before, what other problems they've experienced, and spend maybe a considerable amount of time just getting in some background. And then after having interviewed the patient, if it's a child, we would probably want to see the family, the entire nuclear family. But after the interview, we would want to seek to gather all of the information that may have been accumulated in the past, the medical records, even with children, certainly educational records and other sources of information, so that we're just not operating without corroborative information and a comprehensive take on things. If the patient says they're on medication, we want to know who their physicians are and who's prescribed the medication, and we'll, if necessary, call them and ask them what were the reasons for the prescription, how often do they see them. If they do not have enough contacts with their previous therapists or feel they want to make some changes, we can reassign therapists or ask our either medical or psychological staff to do a reassessment or to evaluate what kinds of treatments they've had before, so we're not repeating the same kinds of things that maybe didn't work.
Mm-hmm. Mm-hmm. So would somebody ordinarily coming into, you're in the Yonkers clinic?
Mm-hmm. Yeah, Central Yonkers.
Central Yonkers. Would someone ordinarily come in saying, I need to see a psychologist, or, you know, and how would it be determined whether they see a psychologist or a social worker? Or is there, you know, a difference depending upon the type of issue it is?
Yeah, I think some of it depends on the type of issue. I think it's more rare that someone says, I need to see a psychologist or a social worker. A lot of times they'll come in saying, I need to see a psychiatrist or I need medication, and that's more clear. But a lot of times it goes through a clinic supervisor who determines who would be the best person to work with a case. And the supervisor has knowledge of the different clinicians in the clinic and their skills, their strengths, and who they work best with. And so they try to allocate the cases that way.
Mm-hmm. Now, at what point would a psychiatrist become involved? You know, someone may, I think a lot of people today think, I need a psychiatrist because then I can get medication. At what point do you become involved? Because it's not appropriate for everybody, I would assume.
Well, Bill and Tim have talked about the evaluation process, the first phase that would be done by a psychologist or a social worker matched by the clinic director. After that initial evaluation, that professional then makes a judgment about whether a psychiatrist should come in and do a secondary evaluation. And that would be an evaluation to help clarify the diagnosis, an evaluation as to whether medication might be helpful or needed. Certainly a person who comes to us who is already taking medication would have a psychiatric evaluation after their initial evaluation to really review that care, decide if that's a proper medication that they want to continue with or change or stop.
Mm-hmm. And when you do a psychiatric evaluation, that's basically a historical perspective? You know, what do you...
A psychiatric evaluation really involves, it's an interview, mm-hmm. takes about an hour, a little bit longer sometimes for families and children. And basically the psychiatrist reviews a number of developmental and symptomatic issues and really draws on the information that's already been gathered and kind of rounds it out, looking for specific patterns of symptoms, patterns that might point to a diagnosis, mm-hmm. that might indicate usefulness of medication, that might suggest need for other tests or evaluation. Mm-hmm. The psychiatrist also tries to get a grasp on the client's medical issues, and if there are any, and are they being followed up appropriately, and then we might have tried to obtain medical records as well.
Mm-hmm. So generally it would seem that you're not the direct resource for someone. You're a consultant to many of the, or psychiatrists in our clinics are consultants to the therapists.
Well, we're a team member and we provide really two services. A direct service to the client, meaning evaluation and medication, and also in a consultation role in terms of working with the therapist, mm-hmm. To plan out the treatment, mm-hmm. and consult when there are changes or important issues that come up.
Mm-hmm. Okay, well, I broadly outlined in the introduction how medical and psychological issues might intersect, but I was wondering if we could get a little bit more specific and discuss this mind-body issue. I know, Andrew, when you and I were speaking, you had a very interesting perspective on mind-body being not really a separate entity. Maybe you want to talk a little
Well, I think there are
about
two sets of issues. One of them is this philosophical issue, which I'll be happy to talk about, and the other one is simply that when people come in with complaints of emotional or mental problems, they also have manifestations in physical symptoms. Where would you like me to start?
Well, maybe we could start with that, the impact of, you know, the medical and issues on their physical health and vice versa.
Sure. Typically, if a person comes to us complaining of feeling depressed or anxious or sad, they will have physical symptoms that accompany that. Not only will they have low mood or anxiety, but they may have problems sleeping, problems with eating, problems with their energy. We know from many studies that a significant number of people who go to general practitioners with medical complaints are actually experiencing the physical symptoms of depression or anxiety. And that when those are properly treated, their physical complaints improve.
So the assessment, someone may come in complaining of, you know, maybe someone can give us an example of how this might work, with the kinds of issues that you're talking about. They don't necessarily know they're depressed. They know that they're not sleeping and they're angry and they're fighting with everybody.
Sometimes it's easier to focus on the physical signs because they're devoid of any emotional issues and blame and any feeling of guilt or other issues that people find too difficult to deal with. They think if they have a physical sign, it can be cured or excised, or a doctor can take care of it. So they might focus and think that that is the problem, when in fact it's just a symptom of, as Andrew pointed out, a broader psychological problem. I think that there's really no physical disorder without a psychological component, even if it's just adapting to how to live with the disorder or how to get appropriate treatment for it. I also think there are no psychological disorders without some kind of a physical concurrent problem that goes along with it. They may not be as prominent in some cases, in some they're quite mixed. Another way I think that this mind-body issue can be complicated and require a team effort to solve problems are areas that are known as psychophysiological disorders. We basically have two nervous systems. We have our central nervous system and our automatic or autonomic nervous system. And if something goes wrong in one or both, each system is going to have to readjust and be involved in terms of trying to fix the problem. Some examples of very obvious psychophysiological disturbances are headaches, which may have a physical origin, may have psychological origin. Bedwetting is a very good example of issues that have to be sorted out as to whether they have a real physical basis to it, whether there's a trauma basis or whether there's just even a genetic basis. So it gets quite complex, and again, a good assessment is the key to the final good treatment.
Now, do you generally how would you pick up that it's a result of one or the other? You know, do you work with?
Well, I think the first step is really this gathering of information and how a set of presenting problems has evolved, so that, for example, an obvious, you know, if a person developed diabetes as a teenager, there are a number of medical complications of diabetes, and then there are a number of psychological responses. And so as we spoke to the person, we would be able to trace those and then try and make interventions to improve function in both of those areas. On the other hand, if more of a psychological issue, say a loss of a relative, it's very common for people when they lose a spouse to develop depression, but also many physical symptoms. So as we traced out the evolution, we would see how the symptoms came to pass, and that would give us clues about how to intervene.
Let me pick up with you, Bill, because you talked a little bit about bedwetting, and I know that this is something that you are a specialist in, and maybe
not myself, but treating kids.
Treating, right, right, okay. Treating children, primarily. How do you know, what is the process of working with a family? Obviously, a family is going to come to you. How do you determine that this is, you know, what the psychological impact is, what the medical issues are, and where do you move with that?
Okay, as Andrew pointed out, the one important aspect of a history is the development of the symptoms and the timing of which the symptoms started. A child who has been having difficulty staying dry at night straight through without any break and has never really been trained at night is actually diagnosed as a primary problem and is often related to either a genetic or a constitutional problem. A child who develops bedwetting much later, after a period of maybe 6 months of being dry, we have to explore further whether there was any changes or stressors in the family, because that can be more of a causative link and not really one of just a primary, and that's called a secondary problem. Both problems, though, are treated with the same type of approach, which is a psychological approach. There's a possibility of using both a physical or a psychological treatment modality in treating this type of disorder. But for the most part, the medications are pretty palliative at this point in our knowledge. They really just treat the symptom. If they're withdrawn, the child starts wetting again, whether or not the wetting was caused by a primary genetic problem or if it was caused by a trauma. Sometimes we also see children who have been abused, and and that may be a causal issue too, and that issue has to be addressed independently. And bedwetting maybe will be treated as well as a concurrent issue. The psychological treatment that's most effective, that doesn't really involve a internal medicine of any kind, is simply awakening the child at the right time, which requires a little electronic device that senses when an underpant gets wet and signals for the child to wake up, or at least to change their state of arousal. This tends to interfere with the bladder contraction, and if it's repeated over and over again, a new response is learned, and the child learns how not to empty the bladder at night. It's known to be very effective, been around for more than 50 years. Earlier on it was called the bell and pad method, but now there are small miniature devices that work quite well. It's about effective in 90% of the cases, where medication is only effective in about 60% of the cases. One of the downsides of a purely psychological treatment, though, is getting the assistance of the parents or the caretakers, because the program cannot be done alone, especially with younger children. Someone is going to have to monitor the program and carry it out every night for at least 2 to 3 months.
But this isn't actually, you know, I guess when people think about tackling psychological issues, it's not really approaching the underlying problem. If the child was, you know, let's say there was separation, or they lost their best friend in school, and that's disturbing to them. This is conditioning. It's kind of behavioral.
It's a conditioning form of conditioning therapy. It's not to say that the other issues shouldn't be addressed, and perhaps can be addressed by a social worker or someone who's skilled in dynamic therapy and will look at the issues around separation or loss. The problem that is presenting, though, the physical problem of the bedwetting, becomes a fixed habit, and it becomes fixed in the level of the autonomic nervous system. And no matter how successful the dynamic therapy might be, the symptom may not abate. So therefore, either both or the definite addition at some point along of the conditioning therapy is quite helpful. And that's independent of the stressor. Now, if the stressor is not removed at all, it'll defeat the conditioning therapy as well.
Right. And I guess along with other disorders that might fall into the same category, just having that condition of bedwetting can also cause additional stresses. And
yeah, the secondary effects of bedwetting are thought to be much more harmful psychologically than what people might have thought, that kids are mentally disturbed and that's why they're wetting the bed. That's not really true at all. There's a wide range of kids who wet the bed, and it's simply a developmental delay in many cases. There's about 10 million kids in our country. That's 10% of all 5-year-olds who are still wetting the bed at night. Again, as I said before, though, the treatment should be implemented as soon as possible, because it does not have serious side effects if we have a good and compliant family and understand how the approach is taken. The secondary effects of not treating are shame and feelings of inadequacy, and a child thinking, you know, here, my younger sibling is not wetting the bed, and yet I am, and I'm being treated like, or I think I'm being treated like the child in the family. I'm embarrassed by it. I can't go to sleepovers. When will it ever abate? I have no idea how to treat it. I've seen my pediatrician. I've seen lots of people, and they all tell me to wait, which is kind of betting the odds, because kids who wet the bed will, about 30% of them will show remission within each year that they get older. But sometimes it'll take 6 or 7 years. So it's better to intervene earlier rather than later.
Right. Are there other kinds of conditions that would fall into this category for people who, you know, adults or other issues that affect children that you can think about?
I mean, both the physical and the psychological
would
problem.
asthma be in this category? Would, you know, eating disorders, asthma, you know, things that people think might be triggered by psychological things, or vice versa? You know,
almost any symptom, either, and especially for example, symptoms of pain symptoms, have to be explored for both the psychological and the medical possibility of causes. Or any disturbance in any life function. And I think I'm thinking about today, Andrew and I were discussing a client who had a drinking water intoxication problem, drank too much water. And we're trying to sort out whether the reason for that drinking of that water was something physical, like a diabetic condition, which we kind of ruled out, or if it were something that was more psychological. Now, one of the possibilities was that this particular client had a history some time ago of drinking, of alcohol, and not having access to alcohol and having limited intellectual capacity. This could have been a carryover of a habit of just drinking for pleasure, or just having to take large quantities of fluid because at one time they were quite pleasurable. And this person, if they can get alcohol, would still drink. But it wasn't an easy issue to sort out, and we couldn't just address the fact that he had his presenting symptom was that he was going to the bathroom too often. He was having frequency problems, but the input was very, very large too. So we had to kind of look back and try to trace, you know, what was the origins of the drinking.
When people talk about psychosomatic conditions, I guess that the general feeling is that these are things people make up, or that they're not real. How do you separate that which is real from that which does psychosomatic have that connotation to a real professional who works with people who might have both kinds of disorders?
Well, I think that there is a bias that we have, that if there isn't a medical test, an X-ray or a blood test that is abnormal, that means that the physical symptom does not exist. And of course that really misses the point, because all physical symptoms are registered in the brain, be they pain, be they changes in metabolism. The brain interacts with all those systems, and there are many subtle things that we do not have tests for. So that when a person comes to us and complains of a physical symptom, well, we believe that they're experiencing that symptom on some level. They may be experiencing pain or tension or changes in heart rate, changes in bowel function. Those are all physical symptoms that may not turn up abnormal results on our medical tests. And this really goes back to this issue of trying to divide up people between bodies and minds and psyches, and it misses the point. Instead, it's better to think of a person as an integrated set of responses, and that responses to outside stress or internal stress really are expressed in really 4 different ways. Physical symptoms, emotional symptoms, effects on thinking, meaning how do you think about, mentate about what you're doing, and effects on your behavior. And so if you take the approach of looking at all those channels of expression of the problem, then that will point you to different kinds of interventions. And interestingly, we know that interventions that work in these different channels often have the same ultimate outcome, and even may cause some of the same effects on brain function or physiologic function.
I don't have that much time left in this segment, but I'd like to pursue it in the next about how you actually can, now with technology, trace how some of these stressors actually do impact brain functioning. When would you refer a family to a medical specialist? We have about 3 minutes left.
Well, that's a tough question because it depends to a large extent on the presenting symptom, the illness, and the history. If we go back to the example of bedwetting, if the child is wetting during the day, which is much less frequent than just wetting at night, especially if it's a little girl, and especially if there are are tests that have shown that there's a presence of a urinary tract infection. We would definitely need a medical opinion to take a look at the anatomy or the infectious process or the neurological process. If a pediatrician has noted that there was some neurological anomaly like spina bifida or birth anomaly of some kind, that would have to be addressed as well and may still require conditioning therapy too. But I think, and also in the long run, if we're failing at treatment, if we have no change and no success, and we assume that we've tried to implement the treatment as best as possible and had greatest cooperation from the family, we might start to think about, let's look for a physical cause. And if we can't find a physical cause, we'll come back again and look to see what other kind of interventions we can use. But certainly a failure would be an indication to do some more medical or physical tests in the case of bedwetting.
Mm-hmm. Do you think that people experience that are we the first level of care, or they go to the doctor and it generally comes to us? Is it a symbiotic relationship with the doctor?
Yeah, it's all of the above, Dale. Yeah. The problem is that often with children, symptoms are presented to a pediatrician who has very little time to sort out the psychogenic issues and the issues that go beyond just a medical problem. At a 15-minute session that a pediatrician might have with a kid, he's going to make sure that he doesn't have an ear infection and that he's breathing okay. And he's not going to ask much about attentional problems.
That might be a long evaluation.
Yeah, that's true.
And to manage care, I think it could be. Yeah.
So that more subtle issues might be missed, and the pediatrician might take the position, let's just wait. You know, this isn't this problem isn't overwhelming. They often use the expression "grow out of it." Mm-hmm. Problems like bedwetting, the neurological tracts are in place as early as 18 months. So there's nothing to grow, and the only thing that'll change perhaps is the child will learn out of a problem. As you mentioned earlier on, problems that are called maladaptive problems don't change unless there's some reason to change the learning or some reward or an outcome. So it's parents sort of have to fish these days to try to find specialists that can focus on the issues, that if they identify those issues as being present, and they have to be persistent with the physicians that they do consult with, or the mental health professionals, and just describe the problem as clearly as possible, and they have to repeat it again if it's not being, if it's not being paid enough attention to.
Right. Okay, well, we're going to pick up on this in our second segment. I promised you it would go fast. We're not all that sweaty yet. I thank you, and stay tuned, because in our second half we'll be talking about other stress and anxiety issues and how treatment is conducted by psychologists and psychiatrists through our agency. Welcome back to the Ways We Care of Westchester Jewish Community Services. I'm Dale Wang, Director of Community Relations. WJCS is funded by UJA Federation, United Way, government grants, private individuals, foundations, and corporations. I am going to repeat that I hope our audience will bear with us tonight. It is a very hot day in July, and we are trying to keep it cool, so bear with us. We're talking tonight about the intersection of medical health and mental health, and issues that WJCS professionals work with people to overcome a wide range of problems. Our guests are Dr. Andrew Levin, welcome, who is the medical director of WJCS and a psychiatrist. Dr. William DeCipio, who is chief psychologist at WJCS, and Dr. Timothy Locke, who is a psychologist in our Central Yonkers program and some of our other programs. We're going to pick up on our discussion from the first half, and what I found interesting in talking to all of you before the program was that some of the conditions that you treat have physical and psychological components that are very often exaggerated responses that would be natural evolutionary reactions. Anxiety, fear, obsession, the kinds of things we had talked about a little. How do these normal kind of responses that people should have turn into difficulties that interfere with somebody's functioning? Tim, you want to take a shot?
How do they turn into it? That's a very complicated question, but let me just step back to say that, yes, I mean, someone who is afraid of a snake, that's kind of a healthy response. We would, we wouldn't want to go near every snake because some of them will bite us and we could die from them. And some people are less afraid of snakes because they know snakes very well and they know exactly which ones to avoid and they know exactly which ones they could pick up and they could do whatever they want. Some people won't go near any kind of woods or forest because there may be a snake there. And so that's the kind of severity that it gets to when people are avoiding things, that it gets to interfere with their lives. Certainly people who are afraid of flying, if your job suddenly requires you to travel across the ocean or across the world, you need to get on a plane. And now you have a problem because you don't want to fly. And you've been able to avoid it before by taking a train or driving, but now you have to fly. And so then those kind of situations will sometimes bring people into treatment. How do these kind of things start? It's a very difficult and complicated question that people have been writing about for years. From a treatment perspective, using the kind of what they call empirically supported, or really the techniques that the literature suggests are the most beneficial, that will have that will actually help people get better. And they've done the kind of double-blind version of these kind of studies to look at these kind of treatment approaches. And they've found that behavioral treatments will help people decrease their anxiety and increase their functioning, and has a number of other positive benefits as well. From that perspective, you don't care so much exactly what happened when the person was 3 years old or 5 years old or whenever something happened, but you assume a conditioning experience. And so you kind of frame the problem and looking at that bad thing that happened as something that happened that later that triggered it. And sometimes we can find out very specifically what that is, and sometimes we may never ever know. But treatment can still proceed and can still get excellent gains even if we don't know the exact cause.
What kind of physiological changes occur when someone might experience an abnormal fear or anxiety, something that would then cause them to come in and say, I can't do this anymore. I just see an airplane and I start to sweat, or I can't go into the supermarket anymore because I'm afraid of people being there, the kinds of things that really interfere with everyday life.
It's interesting you should ask that, because yesterday evening I did a consultation on a woman who had developed panic attacks. This was a woman who was really quite healthy, but was going through a somewhat stressful period in her life, a change in her job, some illness in her family. She was working very long hours. She was probably overtired. And she started to develop episodes where her hands would tingle, her heart would pound, she would get dizzy. And at first, these only lasted a few minutes, and she would try to ignore them, although they were uncomfortable. Finally, they got to such an extent that she had to pull over while driving for 45 minutes. She went to the emergency room, and there the doctors initially thought she was having a heart attack or possibly a stroke. And she went through a number of weeks, actually several months of evaluations for cardiac problems and neurological problems, and the tests were normal, something we talked about before. It doesn't mean she didn't have a problem, it just meant that the problem was not a traditional cardiac problem like a heart attack or a stroke. Instead, what she was having were the physical manifestations of a panic attack. And these are very well known, and they can somewhat be analogized to the physical response that we might have if we were in great danger. If we were being chased by a predator, if we were, as some theorists say, in a cave that was collapsing, depends on who you speak to. But for some reason, this woman's alarm mechanism had just become very oversensitive and was almost going off for no reason. And when people do that, they develop what we call panic attacks. And then the kinds of approaches that Tim uses, behavioral and cognitive approaches, and the kinds of approaches that psychiatrists use, which are medication, really work together to decrease the frequency of these attacks and help people prevent them from happening again in the future.
Mm-hmm. So when you do that, and I want to pick up with Tim on the behavioral approaches and how you actually structure that conditioning, when you do that, do you also deal with the underlying stresses, you know, simultaneously deal with the stresses that started these panic attacks?
Well, in fact, the prescription for this woman that was working quite well was that she was taking a medication that was had basically ameliorated, had blocked her panic attacks. She was able to resume her normal activity, and at the same time she was in a talking treatment to address her family issues and her life issues. Mm-hmm. And at some time in the future she would probably taper off the medication, and most people do pretty well, although some people might need to go back on it.
Mm-hmm. So it would be a multi-pronged approach where you would try to deal with the underlying issue that started some of these.
Well, the only thing I would like to say is this word underlying is a difficult one.
Okay.
We don't really know which came first. All we know is that somehow under a given set of conditions, and this woman may have had a kind of vulnerability, a constitutional vulnerability to develop panic attacks under stress, just as some people develop depression, or some people develop really disturbances in their thinking, or some people develop stomach aches. So there's an interaction between a person's constitution, between their environment, between immediate things that happen to them that lead to the expression of symptoms.
Right. So my husband too has a bad back. You know, they always said he was probably lucky. He probably won't get heart attacks because all of his stress will go into his back, and that's you know, that's your weak point. Whatever your weak point is what gets attacked when you're.
In fact, there is a small group of people who have back problems that have a genetic basis and that run in families, and we know that cardiac disease runs in families, and we know that psychological mental conditions run in families, depression, anxiety. So someone who has panic attacks is first degree relative, a sibling or a parent of that person is more likely to have panic attacks than just someone in the general population.
Sometimes the panic attacks that are precipitated by environmental stresses there's not necessarily an underlying cause, but it could be considered something like a layering. There's a classical teaching case where a patient was complaining that he had attacks when he went over bridges, panic attacks in going over bridges. And he was treated immediately for that kind of problem with a desensitization model that Tim uses. But in exploring this further, and the questions were asked, where was he going when he crossed the bridge? He was going to a job. He had to cross the bridge to get to a job, and he was having trouble with the boss in the job setting. And he was also considering quitting the job, and that would have a great impact on his ability to earn a living and support his family. So was his fear really is it dysfunction at the job, or was it with the bridge? And probably you'd have to look at both and then try to sort out both and use the desensitization model maybe on both stimuli. So underlying causes can be layered in that way, not necessarily a primary and a secondary one.
Right.
And it's interesting that with both anxiety disorders, which we're talking about now, and the enuresis that Bill was talking about before, the question came up with both. If you don't treat some of the underlying things that trigger it, you know, does the person still get better? And well, they could get better, but then they'll go back. And so with both, even though they're very different kind of disorders, the same kind of structure of treatment would have to go through. We would have to always get to what's setting the person off.
Tim, can you explain a little bit how you work with a person to help them structure it so that they change their behavior?
Yeah, and this would vary, you know, based on the anxiety disorder used. But excuse me, the classic example would be that this is grandma's therapy. When you're out on the farm and you're riding a horse and you fall off the horse, what does grandma say? What does grandma say, Dale?
I never would ride a horse. I'm allergic to horses. Uh-oh. Get back on.
Grandma would say, get back on.
Not
Exactly.
my grandma,
Exactly.
but I don't think she had much to do with horses.
But grandma would say, get back on. And that's exactly the analogy with this. When you're faced in a situation where you become fearful, the more you avoid the more that kind of fear and the kind of anticipation of, is it going to happen again, just builds up and builds up and builds up, and can build to the point, like Andrew was saying before, a client described it to me like a tiger was jumping at them, but there was no tiger there. But that was the reaction they were having, as if a tiger was jumping at them. So what we try to do is to help people get back on the horse. And this is very, can be very tricky, and it's kind of a hard sell with people, although on some level it makes sense, that they're afraid of doing something. And so the best way to actually do it is to work towards doing it. The only way out is through. If they're afraid of going shopping from the supermarket because they're afraid of the people, they're afraid they're going to have a panic attack, the best form of treatment would be to bring them shopping. And this is difficult on a lot of different levels. On the one level, for the client, they don't want to go shopping because when they go, they feel horribly anxious. They feel like the tiger's jumping at them. They don't want to be there at all. But what happens over time is when they're exposed to that environment, when they're exposed to the store, to what they're afraid of, the anxiety goes down. And this is something that's been tracked for 100 years with research, back to the days when they were, Pavlov has started all this stuff. They call it extinction or experimental extinction. That response to the feared stimuli extinguishes, it goes down. And a lot of times people kind of intuitively see that this kind of approach can help them. And the therapist's job is to help them through it, to help them stay with the emotions, to help them stay on track with where they want to go, getting back on the horse. Mm-hmm. And it's difficult as a therapist because you see your client become very afraid. Sometimes they have a panic attack right in front of you, but the panic attack won't really hurt them. Mm-hmm. And if they stay with it, it will decrease over time.
So now, do you set that up? Do you accompany the person, or do you set it up so they have a buddy and someone to actually walk them through this, whether it's that or getting on an airplane or, facing any number of things that they could be fearful of?
Could be all of the above. We do what they call in vivo or in real life exercises, and we do what they call imaginal exercises, which you just close your eyes and imagine the situation in your mind. And through both of those, you can get kind of the response that you're looking for. Sometimes therapists will go with clients into supermarkets if it's an elevator, into the elevator, what have you. Sometimes it's harder to do that as a therapist, or maybe something that the person's afraid of happened years ago, and so we don't have a place to bring them or what have you, so we can have them imagine it in their mind, and they can go back and recreate the whole scene in their mind, and it works very, very powerfully with a therapist staying with the person and really emotionally staying with them and helping them through the situation. Mm-hmm. Also the buddy you mentioned, we love to do that kind of thing, is have people in their family, close friends, go through some exercises together, like going in a shopping mall or going on a plane or driving their car, whatever it is they're afraid of, to give them as many different positive experiences. And they may be feeling anxious, but having the support there, can help them get through and decrease their anxiety.
I think I could use this on the golf course. Get up there, that panic just sets in. I can't do this, I can't. Andrew, what is the role of medication? You talked a little bit about, using medication. What is the role of using medication to help people overcome psychological issues?
Medication really is best suited to be used when whatever the problem is, the distress that the person is experiencing really impairs their function, and it does not respond well to a talking treatment or exposure treatment or a cognitive treatment, although they can be done together, and there's a fair amount of research using them together. Mm-hmm. But I think that the tendency that we use at WJCS is to first work in a psychological, behavioral, cognitive kind of mode, and then if the person is not responding, or if they're in so much distress and so much dysfunction, that take a medication approach as well. Mm-hmm. I think it's very important for people to understand that the best treatment is not medication alone. although currently there's been a tremendous blitz of
that was
television
my next
advertising
question,
about the usefulness of medication. There's no question that medicine is useful, but it is not a unique treatment. And there are few problems that people come with that aren't really much more effectively treated with a combination of medication and therapy.
Let's talk about that a little bit, because I think that it is something that's very important and fairly new over the last 2 to 3 years, that you see these pharmaceutical companies saying, you know, you can overcome social anxiety if you take what?
Paxil.
Paxil.
I in fact was part of some of the original research on social anxiety that was done in the early 80s using medication. And I think unfortunately in a 10 or 15 second spot on television, it's very difficult to communicate the complexity of the issue. And the social anxiety isn't just a single thing, it's a whole series of things that go together. So in fact, the recommended treatment for social anxiety is a group therapy that has an exposure component where people practice and learn better social skills, and medication in some cases, but not in all cases.
So we're in a society now where every couple of minutes on TV they're showing you a different medication that can cure anything from impotence to social anxiety to depression, and people want to see the psychiatrist because then they can get that treatment and then they're going to be better.
Right.
How does this affect the way we function with people now who call up and say, you know, I want such and such?
Well, I think of asking people about the marketing value of the TV commercials, that why would they put a drug on TV, and why do they allow that? And I think, I don't think, if a drug is very highly effective and well known and used quite often and prescribed quite widely, I don't think there are many commercials about those drugs. I think the commercials begin when they're trying to market a drug and sell a drug and get more people to use it.
Well, I don't know. Do you think that's so, or it really responds to a different atmosphere in society where people have to take more control over their medical lives because they're going to doctors, you know, and they want quick fixes.
The quick fix is another reason.
So they're basically, the drug companies are saying, ask your doctor. You can't get it without asking your doctor. So are we getting more calls because we have?
I find that, and I've been a psychopharmacologist for almost 2 decades now, and I found that people are more knowledgeable about medications and mental conditions in general, and there's a vast amount of information that they can access on the internet. I think that most consumers understand that they need a guide. They need a professional who can help direct them, help them sift through this vast array of information about a problem and you know, make it specific for them and find out what would be most helpful for them. Occasionally there are consumers who feel that they understand exactly what they need and really don't want to collaborate with you. But the large majority of people are interested in a collaborative approach if you can show them that that's what you're doing. Is let's try to understand what you mean by your social anxiety. And then we enter into a discussion about what situations are difficult and how long have they been difficult. Is this something that you've had most of your life, or is it new because of the new boss? Is it something that runs in your family? Do you have any other kinds of anxiety conditions? How does it affect your mood? Do you use alcohol to control your anxiety? These are all the kinds of things that we try to learn about someone. And people are very open because they want to collaborate and they like that approach. Unfortunately, the television tends to promulgate the idea that it just takes a moment to figure out what the problem is and another moment to write the prescription.
Mm-hmm. And then they don't need anything else.
Another problem, as you mentioned, Dale, is when the TV ad says something like, see your doctor. Now, which doctor? Do you go to your internist? Do you go to a family doctor? Do you go to a psychiatrist? Do you go to a PhD? And I think that's a problem in the way our whole medical delivery, service delivery has been set up in the first place. Depending on who you'll see, you may get a different opinion about whether medication is needed, the type of medication.
Well, actually, it turns out that the majority of medications of psychotropic or mental health medications are prescribed by non-psychiatrists.
By general physicians.
And actually what I have seen and this is really to some extent, we're victims as psychiatrists and psychopharmacologists of our own success, meaning that we have created medications that are easy to use, that are safe, And we have also done our own advertising in the medical field about how effective they are, because we have many powerful treatments in psychiatry which we didn't have a generation ago. And what I usually find is that people come to me who may have tried some medication with a non-specialist. Sometimes it worked fine, but other times they need the expertise of a specialist to find the right medicine at the right dose, taken the right way.
I think the difficulty for the patient is to decide whether it's a medical treatment is best or a psychological treatment, and they're going to get, the opinions are going to be
depending upon which angle they're coming from.
Yeah, depending on what specialist or who they see. And I think that's one of the reasons there's a movement in psychology to gain prescription privileges, so that psychologists can offer not only the medication but also the psychotherapy. And if the feeling of the professional is that psychotherapy or a psychological approach should be tried first, as Andrew suggested we do most of the time, then that could be made by the same clinician and not having to wait to see another clinician, spend another amount of money for an assessment, and so on. But it means the individual would have to be very highly trained. It would have to be a person who's had many years of training in behavioral interventions, and then post-PhD perhaps looking at psychopharmacology as well. As it is now, we are bound to work as a team together because we have different areas of competence that don't overlap.
I want to give you a chance, because we only have 3 minutes left, to talk about the workshop that you're doing, the anxiety and stress reduction, and who your target audience is and what you're going to be doing.
Andrew, you'll have to help me with this. I would guess our target audience is for therapists. Therapists interested in learning more about anxiety disorders in general, and also about anxiety disorders, diagnosis, and treatment, and the different treatments, from behavioral treatment and then also the psychopharmacological treatments.
Yes, I think we have a unique opportunity to do a team teaching.
Yeah, right.
I think there'll be 6 sessions, and we'll try to divide them. But our goal will be to really look at the whole person and look at how the different interventions really mesh with each other, but the unique aspects of them. And also help professionals understand what are the kinds of conceptualizations that seem to be make the most sense now, rather than other conceptualizations that really are not supported.
And my goal is for someone to walk away specifically with the behavioral component that I'll be teaching, that they'll be able to start implementing this in their practice.
Now, is this just for WJCS clinicians or open through our Educational Institute to mental health professionals countywide?
Yeah, it'll be in the Educational Institute, so open to mental health professionals countywide.
And you'll be doing this starting in October?
I think it's November. Did it move to November?
I think we moved it in
late
the fall.
October.
Who should they contact?
Okay, they can contact John Alterman, and we'll be giving another little ad for John Alterman. But I just want to thank you all. I think that, you know, it was a difficult topic to discuss, but I think that people will have a better sense that if they come to WJCS for treatment, it's not you know, one-dimensional. It can be behavior therapy, it can be talk therapy, it can be dealing with medical, psychological issues such as bedwetting, and it can be to be that doctor that they're talking about when they say consult your doctor about medication. So we hope that they have a different sense from having heard this program of the range of options that we present and how we can help them with a range of problems. Thank you very much.
Thank you.
I'd like people to know that if you are a mental health professional and you're interested in taking the workshop on anxiety and stress reduction, you can speak with John Alterman at 949-7699, extension 374, and find out about the Educational Institute at WJCS and a range of programs we have. We will also, on November 1st, be offering a program called The Roles of a Lifetime, Critical Transitions in Adult Development, and that will be at Manhattanville College, Thursday, November 1st, from 8:30 in the morning until 3:30 in the afternoon, and we'll be talking about issues that affect adults throughout their lives. I want to thank you all again, and thank you for viewing, and stay cool.